Welcome to this episode of Orthodontics in Interview. I'm delighted to have my colleague Tif Qureshi, a general dentist, joining me for this podcast. Thank you, Tif, for joining me.
Thanks for having me.
So, Tif Qureshi, he is an internationally renowned clinician, and I really wanted to get him onto the podcast to have this conversation about general dentistry and where that interface lies with orthodontics. He is a private practitioner based not far from London. He's the founder of IAS Academy. And for those who don't know, that is an internationally established educational course and curriculum for general dentists. He's an influential dentist who has been an advocate for minimally invasive dentistry, and part of that has been general dentists also carrying out orthodontics. So this podcast may make some of the orthodontists uncomfortable, but we need to get into this topic. I feel this is something that we need to be just talking about. So a bit of background about Tif. He qualified from King's College London in 1992. He's based in Sidcup, which is just outside London, has an interest in restorative dentistry and orthodontics. Past president of the British Academy of Cosmetic Dentistry, 2019 winner of the Severka Prize, which was a Swedish Society award for recognition for his commitment to conservative, minimally invasive dentistry. He coined the term align, bleach, and bond. He's a board member of the British Association of Private Dentistry and lectures internationally and has also published. Now, what I really like, Tif, is about your philosophy. You put it out for everybody to see. It's based upon your observations, your records, your analysis, and your critique as a clinician. I think that's really interesting and something that will feature quite heavily in our conversation. I'm going to give a final introduction to your academy. So IAS. It's been established for 21 years. You're the chairman and clinical director. A range of courses. The most popular is that of aligners for general dentists. You also offer fixed appliance teaching, labial, lingual, and also the restorative interface. A range of times for those educational components, 1 day, 2 day, certificate, and going all the way up to a 2-year diploma. Now, aligners, orthodontics, and general dentists. In terms of the UK market, 62% of general dentists here offer orthodontics to their patients, and the market is still growing. And my first question to you, Tif, is general dentists carrying out orthodontics. It's a contentious issue. You very much advocate the use of orthodontics by general dentists. What should general dentists be doing? Why should they be doing orthodontics?
I think without doing orthodontics, dentists working in a very compromised environment. If I think back to lots of the work I did when I was the first sort of 5 or 10 years of my career, I still see those same patients. And I see the work that I did, the crowns that I cut, because at the time I didn't realize or understand that actually there was an underlying tooth movement going on and a change in the occlusion. And so I felt I needed to use something stronger to restore that tooth. I still see the same patient, so I know, I can see, I can tell. So the reality is that there are certain situations where dentists really do need to move teeth. Maybe not dramatically, maybe just a very small amount. But that small amount can be the difference between having to cut a crown or not cut a crown and just perhaps place a little bit of bonding on a tooth. So it's important for that reason that dentists are able to at least realize the need to do some ortho and ideally do a little bit of ortho themselves. Without it, I think patients are ultimately put at risk.
Okay. I want to take you back to 2013, where in the British Dental Journal, there was a point-counterpoint with an orthodontist consultant, Rob Chater, and a good friend of yours, the late Anup Hermione. He's a general dentist who also advocated and was part of the IAS. Now, that point-counterpoint gets to really the crux of what the contention is with general dentists carrying out orthodontics. Anup Hermione on one side described it as you just very eloquently did. It's minimally invasive. It reduces some of the destructive other restorative options which are there available. But on the counter side, Rob Chait described how moving teeth too quickly results in instability and tooth movement relapsing afterwards, violating the intercanine width, incisor proclination. Actually, the dependency upon the retainers is such that actually, as soon as the retainers fail, you are going to have relapse. The stability isn't in the occlusion if the focus is just on anterior alignment. So the next question to follow that one up, Tif, is what amount of orthodontics should general dentists be doing?
I think anyone who hasn't done any should be limiting themselves to ultimately 3 to 3, potentially 5 to 5 minor movements. The way that we teach it, I mean, certainly if someone comes on a program, we are not going to be recommending or even helping them, because we do mentoring, of course. We're going to be telling them not to treat a case that would need like a molar 6-7 moved, particularly that involves any posterior cross bites or anything like that. So some minor anterior movement, which may be minor movements such as minor rotations, a little bit of occasionally a little bit of tipping is okay. Not a huge bodily movement. Is perfectly okay for a general dentist to begin with. I think the key thing is that they need to understand how to assess and diagnose a patient properly. They also, by doing that, they understand the difference between treating that patient to an ideal class 1 with everything set up correctly versus an actual compromise, which may just mean that you're only treating orthodontics in a limited objective way, which is kind of a lot of the reason why this stuff came about. And making sure the patient's consented between the two things. So I think as long as the patient understands what the gold standard treatment is versus what they may be getting as a compromise to perhaps stop them having 6 teeth cut down for veneers or crowns, then I think it's perfectly acceptable. And if I go back way before 2013, one of the reasons why I actually started doing this treatment 2005, even before that, actually, when I started fiddling around with aligners and spring aligners years before that, was because I used to refer patients to the orthodontists back in those days, like 99, 2000. And in those days, they would only want to treat the patient comprehensively. Now, I can think of many patients who I referred who then came back to me and said, I'm not having that done. I'll have the veneers. And then I cut 8 teeth and did veneers. And I just, for myself, I thought, look, I've got to just do something different. And as soon as I started to offer those patients some limited objective ortho, which, believe it or not, started with actually some Z-spring aligners before even remember the old Inman aligner thing. I was just fiddling around with Z-spring aligners just with a bite plane just to jump the bite. That really was a game changer for me, because I realised actually, as long as the patient knows what we're doing versus what we're not doing, this is okay. So yeah, that's kind of how it started, and that's kind of why I think in 2013, I mean, in reality, we were still around that time, we were still learning and understanding what perhaps our limitations should be. I think we've got to a stage now where we really know what's right to do, what's not right to do, and obviously developing a pathway where people can actually do the right thing at the right time and not jump on the bus too quickly, so to speak.
In that perspective, when we look at things more globally, like we have statements from different societies in regards to general dentists. The American Association of Orthodontics, they've taken they're from their website. It says, when it comes to your health, you don't want to cut any corners, referring to general dentists carrying things out. And orthodontists are experts equipped with custom treatment plans that's right for you. You've got other countries that just don't let general dentists do it. Brazil, general dentists are not allowed to carry orthodontics. It's limited to just orthodontists. Portugal, Slovenia, France, Denmark. So how do you square this?
It's interesting you say that, because, sorry to interrupt you, Farooq, interesting you say that, because I mean, I've done about 50 courses in Denmark. I've done several in Portugal, several in France. So while they may not be officially allowed, lots of dentists are doing it. And actually in Denmark, I'm quite surprised. I mean, I've spoken at the Danish Dental Association, the Norwegian Dental Associations. I mean, all the Scandinavians are quite similar. So I think that I know some places aren't. And I can tell you something. I reckon if you correlate the most aggressive dentistry in the world, cosmetic dentistry in the world, you'll correlate it to all the regions where the dentists can't do ortho. It certainly was the case in the Middle East a few years ago for a while. And you'd see cases just posted on whether it's Facebook pages or in online conferences of hugely aggressive preps on teeth, and the dentists commonly underneath saying, we're not allowed to do ortho in our country. So that's kind of why things progress the way they did. Sorry to interrupt you, by the way.
No, that's fine. Well, that takes us to that point where it's less aggressive in terms of the restorative side. But where does that stand in terms of things from the orthodontic side and the occlusion? In terms of statements of what is a simple case, Kevin O'Brien wrote about this in his blog in 2018 and described how actually to be able to even recognize a simple case, you need to be fully competent. These are his words from his blog. You need to be fully competent in all aspects of orthodontics. So the question really is on general dentists undergoing short courses. Let's say it's going to be a 2-day course or even something which is a year long and they're achieving whatever, 150 hours in that process. Still, the ability to recognize what is simple and what isn't simple is being questioned here by Kevin. So how do general dentists on these courses then recognize what is an appropriate case?
I think it's absolutely correct. I mean, the reality is that you can't just go in a course and then be done. What you need is mentoring. So that, therefore, after you take a course, it's very important that that course provides you with mentoring, where the first case that you even think of considering, you're going to post that on a forum and let somebody with a lot of expertise look at that case for you and say, no, that case is not suitable. Of course, we've been doing this for the last however many years. So most of the time, people, they'll take a course, they'll post a case up, and the first thing we say is, no, it's not suitable. Find something easier. And dentists, they want to get on and do stuff. But the reality is, I can tell you, if you don't do that, and of course, on our support forum, we actually welcome people who've never even taken our courses. So we see people who just to help them out, to find out where they are if they're in trouble. And we see cases all the time by people who have just done a sort of standard vanilla aligner course. I won't name a company, and the cases are totally beyond the what we would call as an acceptable first case. They're cases that even I would struggle with, with the amount of orthodontics I've done in my career. So I think the key point is, while a 2-day program may not seem a huge amount of time, the whole point about mentoring is you've got somebody's attention. You are one-to-one with that person. You might have 20 or 30 interactions with that person with one case. And we found very well that people learn as they go. That's the whole point. You learn as you go. You post your case up, you look at the case, you then get the patient back, you do a full assessment, diagnosis, treatment plan, you post that back up again, look at all the mentor looks at the photos, looks at the assessment. Then together we come up with a diagnosis-based prescription based on the actual patient, so we can look at all of our ortho-restorative parameters. They then submit that to an aligner company. They then post their digital setup back on a forum. We then look at the digital setup step by step. That might go back and forward 3 or 4 times before we push the button, and then you mentor them through the case. So I think courses, when we hear the term 1 to 2 day courses, it's very easy to think that's what it is. It's not. And I'll be honest with you, if that's what we were expected to do, I wouldn't do that. I only would want to teach a course where those first 2 days are an introduction to somebody who I'm then going to have a online relationship with, probably now for the next 6 months to a year. And I think that's really, in this day and age, particularly with everything being online, that's really the best way forward.
But general dentists still, Tif, do get caught out by this, right? So the General Dental Council back in 24 found that the second highest rate of complaints they got were related to orthodontics. That was 18%, just after dentures. Something in the removable world seems to be the issue. Compared to generally litigation rates against orthodontists across different countries, US, Turkey, UK, is around 9 to 10%. So clearly, this process of general dentists carrying orthodontics gets them stung more often. Now, they actually went into some details to what caused that litigation. Typically, it tends to be communication, but actually for orthodontically related litigation, 57% was the aesthetic outcome, was dissatisfactory to the patient. The 50%, so there was a combination of different factors, was consent. Actually, the third factor was communication at 18. So it looks as though that with what you've described, general dentists still seem to not be able to then deliver once they've made those plans, at least according to what these numbers look like.
I mean, obviously, I'm certainly not training everybody. We are a small fry in this world of orthodontics in the UK. There are some clear big providers here, and a lot of those big providers are literally just teaching people how to scan and submit. And I think that's the important point. It's scan and submit. We will do everything for you. And then they're even encouraging people to do open evenings where you might scan 8 people and then the case gets sent off. Now you're not going to, you need to be spending 1 hour. I mean, I spend 1 hour on an orthodontic exam because I do an occlusal exam and all sorts of other stuff as well. But it takes 1 hour for me to get those records. There's no way you're going to be able to do that in an open evening. And I think that's a problem. I think a lot of the time, while the aesthetic outcome is an issue, if I remember rightly, Dental Protection created a pie chart a few years ago of what causes the complaints, and then actually when the case is gone through a legal process, what you lose the case on. And yes, you're right, treatment outcome, aesthetics, all these things trigger the complaint. But when it goes to the actual legal process, I think it's like 90% of it is lost on a combination of lack of assessment, diagnosis, and treatment planning, and poor communication and consent. A lack of assessment, diagnosis, and treatment planning simply comes from people taking a scan and sending it to the aligner company. And part of the problem is a lot of these people are only taking 8 photos because that's all the aligner company are asking for. And they think submitting the case to the aligner company is actually an orthodontic assessment, and it's patently not. So I think the key point here is that if the start point for all orthodontics, and I think it doesn't matter who you are, has got to be you have to do a proper assessment, diagnosis, and treatment plan. That's a skeletal assessment, it's a soft tissue assessment, it's a dental assessment, it's a molar, canine, everything assessment has to be done correctly, recorded, so that if we, in our case summary, if we know the patient's, a skeletal 2, molar half unit class 2, canine molar, blah, 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 incompetent lips, blah, 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 all of that is written down, then with the inference that we have then said to the patient, look, you are class 2 this, class 2 that, this is what class 1 means. And if you don't accept that you're going to treat that, and you're happy to leave let's say your half unit class 3 molar, you don't want to change that, that's okay. We just focus on the front 10 teeth. What I've just said there is done so rarely in UK dentistry. It's quite depressing. And that is simply because most people just go on a aligner course. That's the reality of it. Every time I'm teaching a new group of people and I show them an assessment form, their eyes pop out and they look terrified by it. I mean, as you well know, it's very easy to go through it very quickly. It becomes very natural. But what's clear is a lot of these people have been doing aligners for a while, maybe 3 or 4 years. They've never even filled one in. That's the problem. And at that point, their records are already indefensible. So I think a lot of those figures come from that. And it's basically that, yes, it's easy to say that some GDP ortho is done badly. I don't disagree with that. I think that's absolutely true. But I think part of the problem is most aligner companies, and I'm not denigrating any particular one, but most of them just want the cases through the door. They're not interested in teaching dentists full assessment, diagnosis, and treatment planning, because the reality is if they were, they'd be getting a lot less cases through their front door. That's the reality.
That's really good insight. Let's relate that now to a specialist orthodontist and their training program. So we have a process where, as a general dentist, you're essentially self-certifying. It's within your competency, at least from the General Dental Council. It's also the same in America, that actually, if you feel you're competent, you feel like you've met the professional standards, you are able to clinically practice. That's different to specialty training programs where you have to demonstrate your competency before you come out with that. I mean, the numbers are, if you look at a specialty 3-year master's program, it's around 4,000 hours worth. Interestingly, in the new curriculum, a sixth of that is just dedicated to diagnosis and assessment, as you've mentioned it. Now, the question really is that the general dentist has to be motivated to engage in this process of assessment, to be able to get a third party to make a decision with them or even for them. Whereas an orthodontist, as they're going through the qualification process, will have to show evidence they can make all those assessments reliably and reproducibly before they reach their certification. So within that, there is a large gap as to where general dentists start from and what the diagnostic acumen is required in terms of a specialist. And the question really is we shouldn't compromise on diagnosis. We should be all, specialist or non-specialist, when it comes to orthodontic assessment, getting to the same numbers. But can we if we don't have that quantity of training?
I think a lot of things are, if you're in general practice every day, you're treating a lot of patients. If you start with simple stuff, really simple cases, and you're guided you're guided and mentored with simple cases. There's no reason why that isn't part of your learning process. You might be spending 5, 10, 15 hours on one patient. And if you've been, the first thing to say is if you've been told no, categorically don't treat that case, which is obviously the thing that we say the most, and then you do start a case that's nice and simple and nice and easy. Well, the reality is over many, many years, not even many years, over a few years, you're going to build up quite a bit of experience. And in truth, then it becomes a case of, well, how different is that from learning how to do anything else in dentistry, be it, endodontics or perio? As long as you're working, I think the common term is, as long as you're working within your skill set, so to speak, there is nothing wrong with doing it. The key is, what is a skill set? I'm saying move 3 to 3. Well, that's okay, but is extruding a 3 that's under the eyeball a smart thing to do? Of course it's not. Not at all. Is a minor tip on a 3, or maybe just shifting it out the way slightly to get a lateral forward a tiny little bit? That's certainly with most people's skill set. I mean, we're talking, minor ortho is and should be minor ortho, and that might be limited by, you may have to. We have caps, for example, on what we would recommend for rotation for anyone with little experience, and then what you do when you've got a bit more experience. But it's hard to be, it's hard to stick to those firmly. We're not, we support dentists and we do mentor them, and I would say some people just don't listen. There is the truth. There are people who don't listen, and you tell them don't treat the case, and you find they've treated the case. What can we do? But most of the time, people start to understand what they need to do. I think another thing, and we will get into this, another thing that a lot of the patients that I treat and I am teaching dentists to treat, interestingly, are patients who have been in their chair for some years, who have very minor tooth movements that the dentist has just noticed. I don't know if that makes sense. So actually, you're kind of reducing your risk slightly by treating a person that who's also had the understanding that this tooth is moving in this direction, that tooth moving in that direction. So I'm much more comfortable doing that than basically sticking a ton of money into Google and getting a bunch of new patients to the door. I don't like new patients. I really don't. And I mean, I'm not saying I don't like them as people, but what I'm saying is that I don't like treating people I don't know. Anyway, I know it's a slightly different area, but I think the key point here, and I think you're valid in what you're saying, that orthodontists do go a lot of training to be able to do. But what I would say is they can do far more complicated orthodontics than the average general dentist should be doing, and certainly the newbie general dentist, so to speak, or the newcomer to ortho. The key is limiting what the dentist can do in a responsible way. That's going to only happen in the framework of who's teaching them, and we know what we do, we know what we let people do, but I'm fully aware of what aligner companies want people to actually do. And there is literally no limit with many of them, without naming any names.
I think that's
where people get into trouble.
And I think that's the case, isn't it, Tif? Is that the unknown unknowns aren't revealed until you've had exposure to that education, and there's no compulsion to that. And I think that's where the specialty is different to general dentists, because actually you're not allowed to go and practice as an orthodontist until you've shown that you can do it. And whereas in general dentistry, the individual makes that choice. I want to put one statement forward to you about the remote treatment planning. This will be contentious, but bear with me. Risks may arise when treating clinician is overly reliant on third party for initial planning, which is typically based upon patient records, including photos, scans, radiographs, and models. That was a statement by the General Dental Council in 2025, essentially describing why there's been an increase in orthodontically related litigation. Isn't that your model that they're describing?
Yeah, interesting. I'm glad you asked that question. The answer is there is a very subtle difference, a very important difference between mentoring and remote planning. Remote planning, you're sending your work to somebody. They are effectively assessing and diagnosing the patient and coming up with a treatment plan. That is not what we teach. I have never written a treatment plan for anybody. What I want is to firstly look at their assessment and diagnosis and tell them what is right and what is wrong and what they should change. And then together we work out a treatment plan. That's really the goal. Remote planning, in my opinion, is a business model. And the idea of it is that the dentist thinks they don't have to think, and somebody else is going to do everything for them. And it comes back to this whole point. I mean, I had on a course not long ago, a couple of people had done a course where they have a remote planner, and they showed me two cases that I saw, and they logged in, and both cases were massively beyond the ability, or what I felt was was the scope of what somebody at that level should be treating. And because apparently an orthodontist is at the other end saying this is all fine, that makes it fine. No, it doesn't. The mentor should only be there. The mentor is there to say, look, don't treat this case, or that plan is not correct. So the plan will come back from a liner company. Or we would say to them, your assessment is not correct, or maybe ask for this, maybe ask for that. Then let's look at the treatment plan. So I think it's a very different model. I think it's quite a unique model in what we do, because we're not remote treatment planning. That's the key thing. We are actually mentoring. And I think that's really subtly different, because the reality is, if you're mentoring, that person is learning along the way, that they have to do the correct assessment, they have to do the correct diagnosis. Because quite frankly, if they post a bunch of photographs on the forum and the photographs are all poor, my message to them is, please go get the patient back for the full series of photographs. Your photographs are currently undefensible. That gets the patient back in pretty quickly, I can tell you. But the problem with remote planning is, from what I've seen very little of that. But I'm happy to be proved wrong.
Yeah. I think it creates that gap, doesn't it? It's a bit like an endodontist setting up a microscope and saying, look, I've set it up, just go and do it now, without actually going through the rest of that staging of the process. Exactly. And actually knowing what the individual's capabilities are and understanding. Exactly. You've spoken before about the envelope of function. Really interesting. Not something necessarily distributed amongst orthodontists, but can I just ask you to explain the envelope of function and how it relates to perhaps the orthodontics?
I mean, the first thing to say is this has to be credited to Pete Dawson. I mean, it's actually a development of the Posselt triangle. Remember that kind of whole movement of the teeth, and you saw those little lines and everything going in various directions, and we all looked very confused at dentist school when we saw it. But Pete Dawson, who was one of the occlusal greats, and his book Functional Occlusion, I think, is definitely worth a read for any dentist, whether they're orthodontist or whatever, perio or whatever. He defined the envelope of function as effectively the pathway that your lower incisors are going to take as they move through all their functional movements. Anterior guidance should be in harmony with the envelope of function. We'll talk about anterior guidance in a minute. The lingual anatomy and the incisor ledge anatomy should also be in harmony with the envelope of function. So your lingual contour should be steep enough to disclude the back teeth, and your lingual contour should also be concave enough so that the lower teeth can move through without any interference. So you can imagine if you had not enough space of the envelope of function, as you chew, there is a chance that you could develop a little bit of a rub between your teeth, and that's a very possible real thing that you see people have. And the anterior guidance, ultimately, which we know, and there's good evidence to support that, is really important for longevity of teeth, in the sense of it builds in muscular protection. So, as I say, envelope function is the lowers moving through the chewing cycle. Anterior guidance is where you can try this yourself. If you bite on your back teeth right now, bite on all of your teeth now, your back teeth, and then slide your teeth forward edge to edge, what should happen in any orthodontic or any veneers or composite bonding end result situation, what should happen is that your two upper front teeth touch your two lower teeth, and then the back teeth separate. Because if that happens, our muscles will then deactivate. If that doesn't happen, your muscles will stay active. Now, what does that mean in the long run? It means that if you don't have enough anterior guidance, and of course in an orthodontic term, that's related into your overbite. So if you have enough overbite of 30% with a 2 to 3 millimeter overjet, you're going to get the patient contacting, and then the front teeth are going to contact. And as your front teeth detect that contact, the brain thinks, oh, I've got to ease off, and the muscles deactivate. Another thing, just to try for yourself, have a go on yourself. Put your muscles on the side. Put your hands on the side of your face and clench your muscles really hard. Feel your muscles clenching as if you're clenching your biceps. Now keep that force down, and just try and push your lower jaw forward and make your front teeth touch, and try and keep that force in place. You can't, can you? No. The reality is, if you can, you need to go to see a dentist. That's the honest truth. But that combination of the envelope function and those parameters around the envelope function are all beautifully controlled by ortho. And and particularly nowadays, what's one really nice thing is with some aligner software, you can actually see a cross section through the teeth, where you can see the teeth like that. You know exactly what I mean. So while we're not seeing an animated image, but sometimes you can see, well, look, the patient's clearly got a constricted envelope. Patient's got a constricted envelope. That's better. Does that make sense? So it's kind of it's a functional it's a movement, and it's a situation that is ultimately controlled by ortho. A constricted envelope will ultimately lead to rubbing and potentially chipping of teeth. An envelope that's too open could end up with a lack of anterior guidance, say, for example, a too large overjet, not enough overbite, and then the patient's lower jaw comes forward and the back teeth touch. Now, that anterior guidance, purely on its own, or lack of, leads to one of the biggest problems globally in dentistry that people don't quite realize is a problem. Lack of anterior guidance, which can actually happen at the end result of ortho. And you were talking at the beginning about what one thing that's really important to monitor long-term with ortho. Well, the anterior guidance is, because the patient loses their anterior guidance, they start colliding more heavily on the back teeth. Now, patients who have amalgam fillings, of which, of course, there are billions of people, if they lose anterior guidance, guess what happens to their back teeth? They end up with crowns. And there are probably millions of people who've ended up with crowns on back teeth because a corner's broken off, a corner breaks off, and the dentist has not realised that the patient doesn't have enough overbite and has lost all their anterior guidance. And just simply protecting that anterior guidance, it might be by doing a little bit of touch-up ortho, it might be by just doing a bit of edge bonding, whatever, just to increase the overbite, could enormously protect the back teeth. And when I talked about earlier about my own patients and the ones that I treated years ago, I've got many patients in the first 5 to 10 years of my career when I knew nothing about ortho, I knew nothing about anterior guidance. I crowned so many back teeth without realizing that actually there was an anterior guidance problem. And this is not just a problem, certainly in the UK, it's global. Whenever I travel all over the world, I'm very lucky to travel, and you talk about this, you see a lot of jaws drop and a lot of eyes go wide open. And I don't really understand why anterior guidance as a subject and envelope is not taught at dental school. It's not rocket science. I can teach a patient that within about 5 minutes. So I don't understand why it's not. But I think gradually over time, who knows, maybe it will be. But ultimately, that's the envelope of function. And it marries really nicely with effectively what I call, basically my kind of reorganization goals, which are based on Gordon Christensen's 3 golden rules, which I think if you're doing any ortho, if you're doing any restorative, if you follow these 3 rules, not a lot goes wrong. I mean, yeah, there's some other bits and pieces you need to do in that. Number 1, you want bilateral even occlusal contacts at the end of treatment, of course, because you want the forces to be spread evenly. Number 2, you want that anterior and ideally canine guidance, because that posterior tooth disclusion through an anterior slide causes the masticatory muscles to diminish quickly, and there's some good evidence to support that. And then finally, you want your unobstructed envelope of function, because we chew and our jaw moves through its chewing cycles, returns to its centric stop. The right amount of overjet, the right amount of overbite is going to allow for that to all to occur without any interference. So it's I hope that answered the question on the envelope. And it's a weird one because there's not a lot of science on the envelope function. It's not like you can just go and read a load of studies on it, but it's so widely understood in the realms of occlusal dentistry and restorative dentistry that, and particularly when you see patients over many, many years, it becomes, once you see it, you can't unsee it, if you see what I mean. It's probably the way to describe it. And it explains why so many people end up with broken restorations on their front teeth and technically their back teeth as a result in the end.
So, Tif, that's very well explained, and you're absolutely right. It's very difficult to actually find any scientific information on this besides a description. All I've got was Lundin and Gibbs, who said that it was an average 0.37 millimeters, but that doesn't really help. Thank you for explaining it. My question next is, so in terms of what the occlusion you described, which is an ideal envelope of function, it is essentially a class 1, from what I'm understanding. an average overbite between 20 to 40%, as it's written down, and overjet between 2 and 4 millimeters. But correct me if I'm wrong. Is this statement of having a unrestricted envelope of function implying that the overbite should be incomplete, i.e., you do have overlap, but you don't have contact? Because that would redefine or conflict to some degree of what a class 1 is defined as, which is the lower incisal edge occludes with a single plateau of the upper incisors or just below it. So both potentially are there. Should there be no completion of the overbite for this unrestricted?
I think if you're saying, is there a centric contact or not, as in, do you have, so I mean, my understanding of, so my overjet is my distance ahead of the lower tooth. My overbite is a percentage of covering. The contact, if whether we have a contact or a gap, is more down to a question of what the patient wants, what they've been used to, do they need it or not. The reality is you can have a contact, but as long as you still have a line on your occlusal protrusion with your marking paper, that's perfectly okay. But you may have no dot on initial contact, but then as you slide forward, you get a contact and then you develop a line with your occlusal paper. Both of those situations are okay. And I've left patients with a contact and without a contact, and we've never really had a problem. I might be trying to deliberately leave space between the teeth because later on I'm going to do some bonding to regain my contact. And we may have to, who knows, make more space because we don't have enough room for my Y, in which case I might do like a dial effect, dial retainer, so to speak. But the reality is, whether we have that contact or not, it doesn't seem to affect the longevity or the interference of an envelope of function. Because ultimately, when the jaw is moving around, it's sort of moving sideways to chew, a little bit of protrusive, but as they slide forward, it wouldn't be contacting on the contact point. It would be further forward on the lines instead of the dots. If that makes sense. It probably doesn't make sense, but if that makes sense, so to speak.
So what my question is that occlusally, in terms of static occlusion, what should that then look like? What are the ranges of this? Is it when you get to 50% overbite, you're likely to have a restricted envelope? At what point do we chime in the assessment and say, hold on, that patient's got a limitation?
I think, I mean, if the reality is, let's say, for example, you had a patient who was a class 2 div 2 with a 60% overbite, and maybe the upper teeth were tilting in and the overjet was very limited, so to speak, hardly anything at all. Well, I mean, even taking that patient to a 50, 40 or 50% overbite is going to be enough of a significant improvement, whether it's a case of intruding the lower teeth or uprighting, slightly intruding the uppers. It may not take it to a perfect class 1 scenario, but it's still going to be a lot better than having a highly restricted or limited overjet and a much deeper bite. I think probably where you're more in not a tricky situation, it's more a tricky situation of when you're treating a patient perhaps who is on a sort of more skeletal class 2 base, and you're treating it as a compromise, and you may find that you have to leave a slightly bigger overbite to then have enough. Because let's say, for example, you're left with a 4.5 millimeter overjet. I'd say in that case, I would accept a slightly bigger overbite on the basis that with my anterior guidance, I want to have a connection as the lower jaw comes forward. If you finished a larger overjet case with a limited overbite, what would then happen is the lower jaw came forward, there'd be no contact on the upper teeth. That's probably the limit of it. And then the last thing is, if you had somebody who was a little class 3 and you couldn't increase the overjet dramatically, then that's kind of when we start to cheat a little bit with restorative treatment, because we can actually build lower incisors back edges forward a little bit as well, which is not an uncommon thing to do on adults if we need to, and you can mask that, and it can all be done pretty non-invasively as well. But it is a cheat.
That's great. That's made that clear. Next, my question is: does orthodontics in itself, do you find, violate this envelope of function? Or actually, if we're aiming for comprehensive orthodontics, by default a class 1 incisor relationship, have we not then resolved any restrictions in it? And then to follow that one up, then the limited objectives dentist, are they not more likely to create a problem with the envelope of function?
Firstly, I think orthodontics, any form of orthodontics, has every opportunity to improve the envelope of function if you're looking to improve the envelope of function. So if you identify the patient has a constricting envelope, your orthodontic movements should improve the overjet and should improve the overbite and should create that degree of space between the teeth for an unrestricted envelope. And in reality, I think whether you're doing it comprehensively or limited objective, you've got reasonable opportunity to do it in both scenarios, because the envelope function really is the anterior region. That's where it's focused. That's the important part, and the anterior guidance comes off the front teeth. So limited objective ortho should be able to do it. Again, it's just going to come down to what movements are needed. If a patient's got a hugely instanding upper lateral that needs a massive amount of torque brought forward that's beyond the scope of a general dentist, and all they're going to do is tip it, that's not good dentistry. And it's going to be one of the things that we'd say don't treat, refer. I think that's what it ultimately comes down to. You have to ideally pick up patients early, and then I know we're possibly going to get to the point about how how teeth move. Once you identify how teeth move and the direction they're moving, then what the interesting thing is, you end up treating patients arguably a lot earlier than perhaps they might have been treated, because they know their teeth are moving into this position, and so therefore the movements become even easier, so to speak.
So coming back to the envelope of function, a question to you is, if the orthodontist isn't planning around it, they've achieved a class 1, and from what I've understood, that's unlikely to result in a restricted envelope. They've talked to the incisor, they've delivered comprehensive management of a particular case, let's say a class 2 div 2. Are you then seeing that these cases then, as the patient ages, can progress onto a restricted envelope of function? And
Definitely.
if these changes are taking place then throughout that process, well, actually, the initial occlusion is almost now, it's in the background, and actually there's other factors taking place. And we'll come on to perhaps next talking about Little's evidence of tooth movement taking place longer term. But actually, if this isn't a constant state of flux, how are you managing that? Patients are always potentially heading in the direction of this restricted envelope.
I think, ortho or post-ortho, post-ortho or non-ortho, for certainly ortho, if they're unretained or not correctly retained and not correctly followed up, and then you will see changes. I mean, I've seen it. We've all seen it. It's visible in every practice. So, we know that retainers should be for life. And the reality is while we all kind of like this idea that a perfect occlusion will actually hold the teeth in the right position the whole life, there's very little evidence to actually support that. I'd invite anyone to show me their patients 30 years later where you see that, because the patients that I've followed over many years who had ortho but didn't have retainers, well, most of their teeth relapsed. And the truth is that without it, those movements will occur. And when those movements occur, very commonly, the envelope gets constricted or restricted. And then you see either chipping on the teeth, or you see an opposing tooth drifting outwards because the envelope's constricted. And this is very common. Now, why have I seen it very specifically? Because I've done something very unique as a dentist, in that I actually take photographs of the patients I never treated. And one of the biggest failings of dental school globally, and I say this with actually some anger in my voice, because I think it is absolutely scandalous that in dental schools they are not teaching people how to take photographs. That some maybe do a little bit here and there, but the general dental checkup, legally, all it requires are x-rays and a dental chart that looks like something a 2-year-old could draw. The fact that it's 2026 and we don't take photographs of teeth is absolutely scandalous. And what that means is dentists are looking at teeth, the patient comes back 6 months later and they can't tell that tooth moved forward by 1/4 of a mil, or that bite's has deepened by 1/2 a mil, or that dentine has worn by 1/4 of a mil. Does that make sense? And someone's coming in and paying me £100 for a checkup and x-rays. If I can't tell them that that's happened in that period of time, why are they even sat in my chair? So, this has got nothing to do with ortho or as a profession or anything like that. This is a dentist problem, a dentistry problem, and it's an education problem. And it's come about because of this ridiculous just idea that somehow you don't need to take photographs. I started using an intraoral camera in 1997, and I've used one every day since. And I then started using as well, not just, I've never got rid of my intraoral camera, but I also started taking SLR photographs of patients from around about, once I started doing ortho, interestingly, I started taking just pictures of people with their teeth. I didn't realize the teeth are moving. It was only after about 5 or 10 years when people start coming back and you start looking and think, oh, wow, that's moved. And then I started reading the evidence and thought, oh my God, there's actually a study that shows that teeth move anyway. But start speaking to all of my colleagues saying, guys, did you know that teeth move anyway? No. And it was a bizarre thing that the evidence was there in front of me. I was seeing it, but the only reason I was seeing it was because I was taking photographs. And here we are all these years later, and dentistry students are still not taking photographs. So I'm just seeing something that's actually there. And the evidence supports it. It's absolutely clear. And when you start taking photographs and showing patients their teeth, it's actually hugely empowering for the patient. They start to really understand what's going on in their mouth. Now, most of the time, I'm saying to them, "Look, don't worry. This stuff happens. This is part of aging. This moves that way. That's right to move that way." And this tooth is going to start to collide, and you might get a bit of a knot, and this one might wear. But by having that conversation in my dental chair every day, every week, 2 or 3 people come back and say, Tif, you're talking about that tooth moving. I'm sure it's knocking my upper one. I can see it's darkening on the edge. Can we fix it now? That scenario I have now compared to myself as a cosmetic dentist 25 years ago, where I was using smile design software, to basically coerce patients into having veneers. And I hate to say that that's what it was. That's what it was. Is just like a life-changing thing. That you're actually educating someone, you're telling them the truth about what's happening to their teeth, and then they make a choice about it versus me telling them this is how great your teeth could look, the scenario. So I hope to answer your question, but if we are all record taking much better as general dentists. I mean, orthodontists is a different scenario because you're not seeing patients as general patients, but general dentists have the opportunity to take regular photographs of their patients. You will see so many teeth move, you'll be shocked. That's actually the key. And I mean, I've got hundreds of examples of patient photographs, and other people just seem to be starting to wake up to take these same pictures now. But that's what I'm trying to teach people to record and track and educate their patients about how teeth move.
I think on this, you've quoted, Little's study is a classic Robert Little's paper where he showed significant change that took place 10 to 20 years post-orthodontic treatment. But those patients also didn't wear retainers.
Yeah.
And this was something you wrote about in your blog on Kevin O'Brien's website. And interesting enough, one of your colleagues, Voss Hobson, put a comment down about how those movements or maturation, as you described, of the occlusion, actually retainers can be preventative to that process. But it sounds as though you've essentially accepted that those movements are going to take place. So do you think patients should be having 2 or 3 courses of orthodontics during their time?
Well, I think the first thing is you've got to identify that those movements are going to happen. And then you've got to tell them that the movement is going to happen. Because as the GDC and as most regulatory bodies say, if you've identified something is going to change or happen, you need to tell the patient. So the first thing is, once you need to tell the patient. Now, at that point, I give them 3 choices. I say, we've got 3 options. Option 1, which most people take, is we'll monitor it. But I'm actually going to monitor it. Unlike most people, I don't mean to say that in a derogatory term, but I'm going to monitor it. So we are going to be aware if things are going to change. Option 2 is if the teeth do start to move and you're becoming worried. Option 2 is just you could wear a retainer. Just wear an Essex retainer because that will stop your teeth moving, and it will actually they do help prevent tooth wear and grinding. They prevent parafunction. They stop further dentine exposure. So there's nothing wrong. I mean, in our practice we've got like nearly a couple of hundred patients who never had ortho who wear orthodontic retainers because they've been educated that their teeth are moving and they chose to stop it. Maybe they couldn't afford ortho. And at some point, many of those patients do and will, because they know what an aligner is like. They eventually say, well, actually, I think I want to do something now. So I think the point about Little study, yes, teeth relapse, and certainly they relapse without a retainer. But the really important part of Little study, and also which was confirmed in Saito's study, and Saito's study So Cyto study looked at patients who'd never been treated, so they were class 1, and they measured their teeth over many years. And Little study has a component of it has a control group of patients who never had ortho, and they measured their teeth. And basically, in Little study and in Cyto study, they showed that the teeth move anyway. That effectively they move at the same rate as a patient who had ortho but didn't wear a retainer. So if we know that, and if we know that teeth are likely to move, 85% of lower crowding cases will get worse. I think it's between 33 and 66%, depending on the continent, of the entire globe has some crowding. That means that 85% of them, their teeth are going to get worse. If we know that, then we should be telling the patient. And the interesting thing is, it's not just the crowding, it's actually how it changes the occlusion. Because if my canines are collapsing in, well, I'm going to start losing my canine guidance. If my uppers start to tip in, I start to develop a fremitus on my front teeth. I've got a constricted envelope. I might start developing non-working and working side interferences. My bite might start to deepen, and maybe I might develop more wear on the anterior teeth. Maybe my upper teeth are flaring forwards. Who knows? Maybe they're crowding forwards, and I start to lose anterior guidance, and then I start breaking my back teeth. So I think orthodontic changes. I mean, you could call them orthodontic changes. You could call them occlusal and functional changes. But those changes that are going on can be intercepted, and I think that's what Ross and I meant in that thread, in the sense of, if you can identify that teeth are moving, what direction they're going to move and how the functional changes are going to occur over the next 5 or 10 years, then absolutely I would want to know, if I was a patient, if I could stop that from happening and just wearing a retainer, or maybe treat it later. I think that was really the argument behind it. That whole kind of, it may not have come across that way, but that's actually probably what we meant.
I think it was great to have that there, especially on Kevin's blog, being orthodontically centric, to have some other ideas and thoughts being put forwards. All right, next question. Tough one. What kind of patient would you say is better to be treated by an orthodontist than a general dentist? And I'm going to ask the question in reverse in a minute, but let's go with this one first.
Okay, I find that quite easy. Firstly, pretty much all children. Okay, I mean, pretty much all children. There's no scenario where any general dentist with no experience, if they're at the end of a 2-year diploma and they're being mentored, fair enough, they can take on a bit more. But if they've got no experience, there is no scenario where anybody under 18, and I would even argue potentially getting towards 20, 21, because it's not actually even the maturation of teeth, it's the maturations of their brain and their compliance, which I think could also be another issue. But there's no scenario where anyone should be treating younger patients. As simple as that. So that's like a red line for us. Then I think it comes down to the complexity of the case. So if the patient needs full mouth treatment, posterior teeth need uprighting, there are interferences on back teeth caused by a crossbite that would benefit hugely from orthodontic uprighting. There are complex extrusions. There are anterior extraction cases. Then that's always an orthodontist referral, always. And I think anyone who takes that stuff on is just asking for trouble. You're just asking for trouble. The interesting thing is, there are so many, we just talked about, there's so many simpler cases to treat. If you're finding yourself having to treat those cases, you are not communicating with your patients properly about what's happening to their teeth. There should be literally no, kind of clash or competition. There's like one type of patient where it's hard, difficult, and you need X years of training to deal with it. And there are other kind of cases that actually are relatively simple, and with a bit of guidance, a bit of mentoring, are reasonably straightforward. So I think that first set are probably, massive open bite cases. You know what I mean? Basically anything that is, let's call it like 100% deep bite case. Pretty much anything that require any sort of functional appliance, et cetera, is what I would say refer.
Next question. What cases are better treated by a general dentist over an orthodontist?
I think the question is whether it's better or not. Okay. In my hands, and I'm certainly not going to say, I can't talk about anybody else, but in my hands, if I'm dealing with a patient, let's just say they're relatively class 1, they've got constricting envelope function, they've got the classic mesiopalatally rotating centrals, laterals falling back in, inverse V developing where there's the constricting envelope on the wear, and I know my prescription to the aligner company is going to be orthodontically and restoratively, or ortho-restoratively, I should say, perfect for that patient, because I've checked, I've done what I call a diagnosis-based prescription, meaning I'm going to give prescription on the midline, the arch form, what I call landmark, so anterior posterior landmark points, how much round tripping we're going to allow based on the soft tissues. Going back to for what you're talking about, going back to remote planning, nobody should be remote planning someone else's, how much round tripping you're allowing or what their biotype is like. Only you can see that. This is exactly what I mean. And it's like, you're the one that has to decide, is this good biotype or not? Do I limit round tripping, or do I completely forbid it, or do I allow some depending on the biotype, etc., etc. Also other things like vertical landmark points, which tooth is in the correct position for the face, what's actually intruding, IPR timing. So all of these things that we can do. So all the things that I can input, like there's other things, for example, like if I want really good aesthetics and nice visual connectors, I'm going to measure all the teeth, and then I'm going to give the aligner company certain instructions of which ones have more IPR timing. Do you see what I mean? All that sort of stuff. I work with some amazing orthos who are brilliant, but I can do that bit better. I can do that bit better because it's tied to my restorative treatment. But if it involved, as I said, if it involved all the other stuff that we were talking about before, like full mouth treatment, uprighting back teeth, I'm not a user of TADs or anything like that, I'd be sending it to my orthodontist every single time. That's the way I view it.
That's great. So it's really the complex cases to the orthodontist, the ortho restorative. Actually, that's the general dentist.
Yeah.
Tif, we have a custom on the podcast, and the last question I ask you is an open one, and it's what one piece of advice would you give to the orthodontists and dentists listening to this podcast?
Well, I think to dentists, I think you brought a lot of this up earlier very well in the perceived issues, or the actual issues, not perceived, the actual issues and risks of dentistry. I think I know we've seen the evidence. They really come from shortcutting assessment, diagnosis, and treatment planning. I think you need to learn how to do that yourself, and that's what we teach, and we mentor that. And I think you need to get away from remote planning. Personally, as a general dentist, you need to understand how to assess and diagnose a patient yourself. And I also think that any general dentist doing ortho should, right from the beginning, be aware that they're actually treating occlusion as well. This is an occlusal treatment. It's not just orthodontics. It's occlusal treatment. And if you plan it that way, you'll get a better outcome. I think to orthodontists, I'd say, and actually, we've had loads of, we have one or two orthos on every single one of our courses, believe it or not. And what they're really interested in is the ortho-restorative part. They know the ortho, but I have a lot of orthodontists who, come in to learn how to do dull. In fact, last 2 or 3 weeks ago, we had 7 from Mongolia who are all specialists who are learning how to do edge bonding and dull build-ups, because dull build-ups, if you're an orthodontist, you don't know what that is. It's actually a restorative treatment that is orthodontics. It's actually an orthodontic treatment done with restorative treatment, and it's an amazing tool to learn. So I would say to orthodontists, I think that actually the ortho-restorative element, particularly if they're interested in treating more adults, could really open up their practices a lot more. And I don't see any reason why orthodontists shouldn't be doing a line bleach and bond just as much as dentists. Why not?
Excellent. Tif, thank you so much for joining me on Orthodontics in Interview. I really valued your time and the conversation that we've had exploring this topic, which is controversial, but I think we've got some good things to go home with as to where the advantages of one versus the other are, but also where the collaboration lies as well. So thank you so much for shedding some light on that.
No worries, Farooq. Thank you so much for having me, and thanks to all your listeners for listening.